So here is a 54-year-old female named Amy, and came with a 1-year history of fatigue, shortness of breath and dizziness, weight loss, increasing severe back pain, bone fractures, skin lesions, and large tongue and infections. Okay, in exam also they will give such a clinical case where there will be a guy of 65 years old and history of radiation exposure. He will be working in X-ray field, and he will come with a proteinuria, means like some same symptoms. Okay, which you are saying now. Let's start multiple myeloma. So, pathogenesis of multiple myeloma, the transformation of malignant plasma cells involves multiple mutational events. Okay, mutation because of radiation exposure or environmental factors. Malignant plasma cells have specific adhesion molecules for stromal cells of bone marrow. Malignant cells attached to the stromal cells of the bone marrow. The stromal cells produce a cytokine, that is interleukin 6, which stimulates the growth of the plasma cells, prevents apoptosis, and stimulates osteoclastic activity. So remember what are the what is happening here. The stromal cells produce a cytokine interleukin 6. So interleukin 6 is the bastard which causing stimulates the growth of the plasma cell, prevents apoptosis and stimulates osteoclastic activity. So interleukin 6 हमारा दुश्मन है, तो ये क्या करा रहा है, इतना सब गंदगी मचा रहा है हमारे बॉडी में. ठीक है, इंटरलूकिन 6 ही कारण है मल्टीपल माइलोमा के लिए. So malignant plasma cells produces interleukin 6 and it also causes vascular endothelial growth factors. Because of that there is angiogenesis and monoclonal protein accelerates the catabolism of functional polyclonal immunoglobulins. Characteristics of myeloma cells are translocation of immunoglobulin heavy chain gene gene 14 to the proto-oncogenes interleukin 11, 16 and 20, missing of all or of a part of chromosome number 13. So light chain immunoglobulins produce orange. ठीक है. Next, osteoclast activation by interleukin 6, bone destruction and lytic lesions with resulting bone pain, pathological fractures, cord compression, symptomatic hypercalcemia and osteopenia. So interleukin 6 causes bone destruction. Okay, there is bone resorption, osteolytic bony lesions, punched out lesions. Okay, infiltration by the plasma cells, pancytopenia, hypergammaglobulinemia, paraproteinemia, resulting in immunosuppression and susceptibility of pneumonia, streptococcus pneumonia, staph aureus. Immunity is decreased, anemia seen. Immunity is decreased, anemia seen, and there is bony destruction because interleukin 6 is produced. Because of that, osteoclasts get activated and osteoclast is destroying the bone. Punched out lesions are found. Extra osseous spread mainly to the kidneys. Okay, the osteolytic bony lesions may be seen on bone, spine, vertebra. Okay, so here is a mnemonic to remember what is happening. CRAB. Okay, hypercalcemia, renal insufficiency, anemia, bony lesions. Remember CRAB, crab, for clinical manifestation: hypercalcemia, renal insufficiency, anemia, bony lesions. So now coming to the lab findings of multiple myeloma. Okay, multiple myeloma is a monoclonal proliferation of plasma cells, that is myeloma cells in bone marrow, arising from the malignant transforming B lymphocytes. Okay, so there is an antigen come and presenting with a B lymphocyte. So that B lymphocyte converted into the plasma cell, and that plasma cell will produce the antibodies. Okay, this is the normal mechanism. So what are the monoclonal antibodies? How are the monoclonal antibodies produced in multiple myeloma? Here is a B cell. Okay, this B cell converted into the plasma cell, and this plasma cell multiply so many times and produces number of plasma cells. Okay, and this number of plasma cells produce a single type of antibody, same monoclonal. All the antibodies produced by this plasma cell, all the plasma cells produces the same kind of antibody. Okay, so these are the monoclonal antibodies which bind to a only particular antigen. These are the malignant transformation of the B lymphocytes. Next, causes is still unknown. Okay, but in exams they will give a person came with radiation exposure. Okay, but research have suggested that genetic abnormalities such as a CMYC gene or environmental exposure. Mainly I want to discuss laboratory diagnosis. Okay, this is the most important part. We will describe it under 4 things: blood and bone marrow picture, urine analysis, serum studies and radiological studies. Okay, blood and bone marrow picture, urine analysis, serum studies and radiological studies. Now first starting with the blood and bone marrow picture. Okay, how will be his blood, means the patient's. First coming to the hemoglobin, it will be decreased. Hemoglobin is decreased and marrow replacement and renal damage with resultant loss of erythropoietin. So as there is renal damage. Okay, as there is proteinuria, means loss of protein, that is light chain are passed in the urine. That is the reason where there is renal damage. Okay, and hemoglobin is decreased. RBC you will see Rolex formation. What is Rolex formation? The RBCs are stacked up, and there is Rolex formation due to the excess of immunoglobulin. Rolex formation means this. RBCs will be stacked upon one on another. Okay, they will be stacked like this. This is Rolex formation. Next is plasma cells in the terminal stage of multiple myeloma. ESR, erythrocyte sedimentation rate, is increased due to the Rolex formation. What is ESR? Erythrocyte sedimentation rate. It is calculated by two, that is by Westregen's method and Wintrop's tube. Westregen's tube and Wintrop's tube. Okay, it is increased in multiple myeloma because of Rolex formation. Westregen's tube and Wintrop's tube. Erythrocyte sedimentation rate means the at what rate the RBC gets settled downside. Okay, hematocrit, that only. Westregen's and Wintrop's tube. Increase in the number of plasma cells, usually more than 30% of the marrow cellularity. As there is malignant transformation of the B lymphocyte, there is increase in the number of plasma cells more than 30% of marrow cellularity. That as there is a increase in marrow cellularity, there is also bone destruction. Okay, therefore you will also get increase in the calcium level. Plasma cells of multiple myeloma are very similar to normal plasma cells, but they may also poorly differentiated. These different types of plasma cells, the one among them is flame cells. Okay, sometimes cytoplasm may show irregular borders, flaming with peripheral free borders showing orange red color. Okay, so I will show a picture where you will get the flame cells. Remember these flame cells. Okay, in biopsy we can make out Russell bodies. Another one is a Russell bodies, eosinophilic inclusion made up of immunoglobulin. Okay, I will also show flame cells and Russell bodies along with Mott cells and Dutcher cell. Okay, there is a picture. All these are included in that only. Okay, next is urine analysis. We will take a urine sample of the patient and we will do urine analysis. Upon urine analysis, we will see Bence-Jones proteins. Okay, what are these Bence-Jones proteins? These are the monoclonal immunoglobulin light chains, that is kappa or lambda, synthesized by the monoclonal plasma cells. Okay, they are characteristic. They have characteristic thermal solubility. What are Bence-Jones proteins? These are the monoclonal immunoglobulin light chains. They have characteristic thermal stability. Okay, this is the most important thing. At room temperature, the urine is clear, and when you heat at 40 to 60 degrees Celsius, they will form a PPT. When you further heat it for 100 degrees Celsius, they will redissolve and urine will become clear. Okay, and after heating, we will let it to cool down. When they return, coming to the 40 to 60 degrees Celsius, they will again form a PPT, and after coming to the room temperature, there will be a clear urine. Okay, so it means that at 40 to 60 degrees Celsius, they will form PPT. 40 to 60 degrees Celsius, they will form PPT. Okay, now coming to the serum studies. In serum studies, there will be elevation of M protein. Okay, what are M proteins? These are the abnormal proteins produced by the plasma cells. Serum protein by electrophoresis. What is by electrophoresis? You know that gel electrophoresis. We also use this electrophoresis for differentiation of isoenzymes, that LDH 1, 2, 3, 4, 5, and also for lipoprotein, that VLDL, LDL, HDL, and cholesterol. And we will also use for serum electrophoresis. Okay, where we will put our serum and it will be differentiated to albumin, globulin, that only. A is albumin, alpha 1, alpha 2, beta, and gamma. Okay, so here you can see there. There is elevation, formation of M band in the gamma region. Okay, serum protein electrophoresis separates different proteins in the serum on the basis of their charge. Okay, charge is applied, positive, negative, as proteins are negatively charged. M band difficult to the gamma globulin. Most common serum monoclonal immunoglobulin is IgM. Next, coming to the IgG, that is 55%, IgA 25%. IgM, IgG, and IgD are rare. Okay, most commonly is IgG. Most common IgG elevated. IgA is next 25%. IgM, M, D, and E are very rare to see. Most myeloma are associated with greater than 3 gram per deciliter of the serum hemoglobin, and more than 6 milligram per deciliter of urine has Bence-Jones proteins. Okay, these are some values. We will handle them later. Serum calcium is elevated because of extensive skeletal destruction by the neoplastic plasma cells. As there is increase in the plasma cell proliferation in the bone marrow, that is the reason the bone degrades, and you will get free calcium in the serum. Next is blood urea, that is elevated, and also serum creatinine is elevated. As these immunoglobulin light chains are passing to the while are getting filtered through the kidney, they will form renal damage. Okay, that is the reason blood urea is elevated and serum creatinine is also elevated. And next we will do the radiological studies. Upon radiological studies, you will see punched out lesson on the skull. Okay, now I will show the all the pictures. Okay, and there is some mnemonic also that I will also tell. Okay. So here is the diagram. You can see these are the myeloma cells. Okay, these are the myeloma cells binding to the VCAM, vascular cell adhesion molecules, to the BMSC, that is bone marrow stromal cell. So these myeloma cells have affinity towards the bone marrow stromal cells. This bone marrow stromal cells produces interleukin 6. The interleukin 6 gives the superpowers to these myeloma cells. Okay. So you can also see these myeloma cells produces rank ligand, tumor necrosis factor alpha, MIP1 and interleukin 3, which converts osteoclast precursor cells into osteoclast. Okay, active osteoclast, which causes the bony resorption. That is the reason you will see osteolytic bony lesions. Along with that, these myeloma cells also produces VEGF and HGF, etc., which causes angiogenesis. Okay, endothelial cell proliferation, angiogenesis. This is a very beautiful diagram which explains everything. So take a screenshot of it. So I already said that we will see different types of cells. Here you can see the first one is a plasma cell. Okay, next one is the binucleate plasma cells. Okay, here the nucleus will be cartwheel appearance. Okay, cartwheel, you know that cartwheel, the nucleus will be cartwheel appearance, that is binucleate. And then is a plasmablast, another one flame cells. It looks like a flame here, flame cell, so you remember. Next is Mott cell. Okay, before Mott cell you should remember Russell bodies. This plasma cell, here is a nucleus. Okay, here all the immunoglobulins will get accumulated. This will give the Russell body. Okay, this number of Russell bodies together all together form the Mott cell. Okay, Mott cell is nothing but number of Russell bodies in a plasma cell. This is from the Mott cell. So don't get confused Mott cell as adipocyte. Okay, it almost look like adipose, which stores fat in it, but it is not fat. Remember. Next is the cytoplasmic crystalline rods, Dutcher body. Okay, Dutcher bodies. Oh, these are the different types of cells you will see. I will show you the real picture of the Mott cell. Okay, these are all the Mott cells which have Russell bodies in them, number of Russell bodies. Okay. Clinical manifestation of multiple myeloma, that is bone pain, spine, hip, ribcage, that is osteolytic bony lesions in weakness and fatigue, nausea, constipation, etc., recurrent bacterial infection because of decreased immunity, renal insufficiency. Remember CRAB. Okay, hypercalcemia, renal insufficiency, A for anemia, B for bony lesions. Another one is for treatment. We will left with the treatment of multiple myeloma. How it is treatment? There is almost no cure for multiple myeloma, but still we will try with something. Okay, steroid therapy, dexamethasone, prednisolone, stem cell transplantation, autologous or allogenic, and radiation therapy. Okay, you can try all this. Hope so it get treated soon. So at last I want you to remember this. Okay, in examination they will give a patient will come, old female, 54-year-old female or male, working in X-ray industry or get radiation exposure, some history will be there, and with the symptoms of fatigue, shortness of breath and dizziness, weight loss, increased severe back pain, bone fractures, skin lesions, enlarged tongue infections, etc., etc. These are the symptoms, most common presentation of the multiple myeloma patient. That's it guys, see you in the next video. Until then, Jai Hind, Jai Bharat.